So it's my pleasure to introduce our moderator for the panel. It's Dr. Callie Barrett. Dr. Barrett is a Toronto-based critical care physician and scientist. Her research evaluates critical care processes, outcomes, and costs to support policy development that seek to increase the value of the care delivered, improve clinical outcomes, and support ongoing clinical and technical innovations. Dr. Barrett played a pivotal role in Ontario's role to the COVID-19 pandemic as a key contributor to the health system capacity modeling and as an assistant scientific director on the Ontario COVID-19 Science Advisory Committee. Dr. Barrett is an attending physician in the Recover program at the Toronto Grace Health Centre, is an affiliate scientist with the Toronto General Hospital Research Institute, and is an adjunct lecturer in the Department of Medicine at the University of Toronto. Dr. Barrett is going to introduce the rest of the panel. So please welcome Dr. Barrett to the stay seated.
All right. Hi, everyone. So I'm going to start off by introducing our panelists. So I'll start with Mr. Gino de Angelis, who's joining us virtually, I assume probably from Ottawa. And he is a clinical research manager for medical devices and clinical interventions at Canada's Drug Agency. So maybe you can hint that we're going to talk a little bit about implementation and evaluation. We also have Dr. Aigus. She's a lecturer at the University of Toronto, an emergency physician at University Health Network, and co-director of postgrad education for emergency medicine at UHN. She did her medical degree at McMaster University and did her family medicine and emergency medicine training at Western University in London, Ontario. Next, we have Dr. Sandra Isabel. She is an assistant professor, a medical microbiologist, a pediatric infectious diseases specialist at the University of Laval in Quebec. She did her medicine at the University of Laval, while she also did a PhD, MD PhD, and then did all of her clinical training in peds infectious diseases, medical microbiology, and a postdoctorate at the University of Toronto and the Hospital for Sick Children here. So, what are we going to talk about? We are hoping to have an interactive session here, so I hope that you've got the app on your phone, the Slido app, under AMR Symposium and polls. We are going to be polling the audience. We're going to, if you saw this morning, there and Dr. Fox-Robichaud's talk about the sort of the links between sepsis and AMR, we're hoping that we're going to be able to demonstrate to this audience some of the challenges that clinicians face with respect to antimicrobial resistance and sepsis. We're going to talk a little bit about the current state in terms of how we do testing and what it looks like for clinicians on the front lines. We're going to explore the role of point-of-care testing and then talk about some of the challenges with implementation and getting innovation to the front lines. I'm going to preface this by saying this work is essential, and the World Health Assembly has actually asked the world to do this. So in the 2017 World Health Assembly call on member nations to reduce the burden of sepsis, one of the urges to member states was to promote research aimed at innovative means of diagnosing and treating sepsis across the lifespan, including new research for antimicrobial and alternative medicines, rapid diagnostic tests, vaccines, and other important technologies, interventions, and therapies. So we have been asked by global health leaders to do better in this field. All right, so first off, I want a show of hands. Please raise your hand if you're a clinician. All right, raise your hand if you're not a clinician. Okay, raise your hand if you're in pharma or tech, like health tech. And then the rest are in science. Just yell out what fields you're from. Engineering, basic science, microbiology. Okay. Very well educated but heterogeneous audience. Awesome. Okay, so we're going to start with a clinical vignette. All right, so I'm going to pass this over to Dr. Gu.
Okay, perfect. So nice to meet everyone here. A pleasure to be here. So I have 2 clinical vignettes for you, 2 spectrums of the age groups that we see. Not everyone who comes into the emergency department is very sick. And so part of our job is to determine, is this patient sick? Is this patient not sick? And then to determine what we need to do for them. Is it supportive management? Is it antibiotics? Do they need admission? Do they need ICU? And so hopefully in these clinical vignettes, you'll get a taste for some of the common patients that we might see. So for the first clinical vignette, we have a 6-month-old infant presenting at a rural hospital. So these are pretty low resource settings. You're probably the only emerge physician there. Born GA 34 weeks, so preterm, 3 days NICU admission after birth. So obviously this is a patient who might be at more risk for developing sepsis or infections later on. They've had 2 emerge visits already for COVID and RSV, and they're presenting with 3 days of cough, congestion, basically upper respiratory infection symptoms. They've had normal wet diapers, they're eating and drinking well, no nausea, vomiting, diarrhea, other focal infectious symptoms, and their brother is sick with similar. On exam, their vital signs are stable, they're afebrile, they appear well. So here, would you order any additional tests for this baby? Like, what else would you do? Would anyone, can you raise your hand if you would do additional tests for this baby, or you're happy here?
We're down to 50-50,
Yes.
one and one online.
Yes, so, okay, I guess some people would order additional tests. And would any point of care testing be helpful in this situation? Can you raise your hand if you think point of care testing might be helpful?
Few.
I see some head nods. Yes, I see some hand raises over there, excellent. So we're here to talk about point of care testing, how it might facilitate acute care. So in these situations, we don't always know if it's a viral illness, if it's a bacterial illness, and sometimes point of care testing can be very helpful for either us to rule something out or rule something in. So we saw that really with the COVID pandemic, with the rapid testing, we could really say that, oh, this patient has COVID, potentially other comorbidities as well, but they definitely have at least one viral illness here. And so for this baby, let's say they test positive for a viral illness, perhaps we're more inclined to discharge this patient home without additional workup. So in our second clinical vignette, we have the other spectrum of age, a 78-year-old female presenting to a community emerge. So a little bit more well-resourced. You might not be the only emerge physician there. They have a fever for 1 day, Tmax 38.2 degrees Celsius. And they're afebrile in the emerge after Tylenol. They're having cough with yellow phlegm, congestion, some mild shortness of breath on exertion. And they do have some past medical history, as many 78-year-olds do. So diabetes, high blood pressure, and their vital signs are stable. So their oxygen saturation, 97% on room air, heart rate 80, blood pressure normal, respirate 18. On their labs, you've done, your basic labs, white blood cell count is 15.1, and then otherwise unremarkable. Chest x-ray, you've done that already. You have some perihilar markings, so commonly seen in a viral infection. No focal consolidation that you see, but obviously they've only been sick for about a day. So what about in this situation? Any additional tests that you would order? Raise your hand if you would order any additional tests. Yes, I agree. And would point of care testing be helpful here? So you can imagine that some testing might be not point of care, so blood cultures, for example, might do a urine on this patient. You're probably doing the full sepsis panel on the 78-year-old, but certainly point of care testing could be useful as well, whether it's for determining, do they have a concomitant or a viral illness? Do they need to be isolated? Do they need a negative pressure room? These are all things that we kind of think about in the emergency department. And so definitely I could see a role for point of care testing here as well, and also to help facilitate with disposition.
So I'm going to take it now, I'm just going to give you a vignette sort of from some of the types of patients that I've seen. So now, let's say we have a 56-year-old male who's been admitted to the intensive care unit for 6 days. He was admitted with COVID-19 pneumonia. He did receive corticosteroids for 5 days, so the dexamethasone that we just heard about. But now he has new low blood pressure, hypotension. His lactate is elevated, which is a sign of decreased oxygen delivery to the cells. He's got increasing oxygen requirements. His ventilator settings have increased, and his white blood cells have increased. So, and this is what his chest x-ray looks like. I got this off the web, so this is not a real patient chest x-ray, but you can see there's an endotracheal tube in the trachea, and on the patient's left, our right there, you can see there's increased white fluffy stuff, so stuff that doesn't look great. So Okay, so we do a bronchoscopy, which means I stick a tube down the patient's lungs, I get some mucus and some samples, and I send it off to the lab. I ask them to culture it and tell me sensitivities. And I want to start antibiotics because this patient has septic shock. They have what I presume is a lung infection, a hospital or a ventilator-associated pneumonia. And at Toronto General Hospital, for instance, now all of the hospitals in the GTA downtown at the academic centers, we can actually access these. Now this one, you'll see the last time it was updated was December 31st, 2022. But this tells me what the sensitivities are to the antibiotics in my intensive care unit if I'm working at Toronto General Hospital. And when we have a ventilator or hospital-associated pneumonia, the most common pathogens are gram-negatives. And you can see one of the, I hope this, oh, nope. Sorry. There we go. This is, nope, back one more. Sorry, guys. There we go. There we go. Does that show up, the pointer? No? Okay, so I'm going to walk over here. So most people's sort of go-to would be Pip/Tazo. And if you look at all gram-negatives at the ICU in Toronto General Hospital, 57% of gram-negatives were actually not sensitive to Pip/Tazo. So at this institution, what would commonly be a regular sort of empiric antibiotic coverage for a patient with a ventilator-associated pneumonia, very common presentation, our sort of go-to drug would be Pip/Tazo. So at our institution, if I was at Toronto General, we would actually be giving meropenem as our empiric antibiotic. This, if I didn't have this antimicrobial sensitivity profile for my institution, and let me tell you, many don't, this would be a very challenging scenario. You wouldn't really, or you would know potentially that you're going to maybe start something that's really broad, but actually will have no help, and that your patient's just going to get worse and you actually haven't given the right antibiotic. Okay, let's go to an even more complicated case. 48-year-old male who's 21 days after a double lung transplant for pulmonary fibrosis. They were extubated, which means they were taken off the ventilator on the second day. They have a past history of hypertension, so not really much. The donor lungs from the person that gave their lungs, those lungs, when they were at the time of being explanted from the body, grew Staph aureus. And the patient completed a course of cefazolin, which would be the appropriate antibiotic. But what I'm going to tell you also is that actually, but before we knew that, we didn't have cultures back, so we empirically started them on Pip/Tazo just to cover, because most of these lungs are from people who've been in an ICU, so they probably they're at higher risk for having a ventilator-associated pneumonia. So we started this man on Pip/Tazo, and then when we got the cultures back, we down-stepped to cefazolin. He was discharged to the step-down unit, so was doing really well, but then on post-op day 9, deteriorated again. Overnight admitted to the ICU, has new pneumonia, new shock, new acute kidney injury. And if you look at the antimicrobial susceptibilities in a transplant unit, it's even worse, because these are the patients who are on immune suppressive therapy. They're receiving lots of broad, empiric antibiotics. And you can see in this group, all gram-negatives, even meropenem now is down to 72%. So I'm not even confident if this guy came to my ICU with new hospital-associated pneumonia that meropenem is going to be good. And I'd be looking more over in the tobramycin range, which, you know, we're a little nervous about starting tobramycin in patients. So these are real legitimate clinical problems in adult intensive care units. Oh, sorry. I guess I should end that by saying in all of these scenarios, point of care testing would be incredibly helpful. So in that first scenario, where it was someone who'd been previously exposed to corticosteroids, which we know reduce immune system function, the ability to say, okay, which bacteria is this? Is this Klebsiella? Is this E. coli? Is this Pseudomonas? That might actually be able to help me decide which of the antibiotics I need to use based on my local institution's sensitivity profile. Here in this case, we could have reduced the amount of Pip/Tazo use. If we'd known when that patient came out of the OR, we did a sample from the lungs, did a quick point of care test, we would have been able to identify that was Staph aureus, hopefully it was MSSA, so sensitive to cefazolin. We could have avoided all that gram-negative coverage and just gone right to cefazolin. And then here again, it would be the ability to identify the organism immediately and then have that guide which antimicrobial I use. And even better, imagine if that point of care test also told me which antibiotics that bacteria was susceptible to. Huge change in clinical practice. I'd be able to narrow my antibiotics at day 1 at the moment of starting antibiotics for septic shock. Okay, now you can go.
It's great to be here with you to talk about AMR, as unfortunately we see more and more in clinic. I'm going to switch gear and go back to little babies. So we're going to talk about cases in pediatrics. I've worked in different hospitals, and the one case I'm going to present is not like an actual case. It's a scenario based on experience. So here we have a 2-week-old boy who is like post-op day 5. He had like a congenital heart malformation, so therefore needed to have a heart surgery and had like an open heart surgery to correct that. And I'm called as an infectious disease doctor because there is fever and there is increased FiO2 requirement, which really means that this little baby is requiring more and more oxygen, and it's unusual for him. So as we do like an assessment on the patient, we also evaluate the epidemiology of that patient, right? And then this patient has been in the ICU a lot, so he's more at risk of having multi-drug resistance organism. Also, the mom had like a virus, so hopefully it's just like a small virus for this baby, and we can, figure this out, and it's not a sepsis, but we're not sure. And of course, there's always like those other stories that happen, and that in some scenarios we will hear that the mother had HSV at the end of pregnancy, and of course this also can give sepsis in a baby. So those scenarios where we get like multiple factors that are confusing our diagnostics are very common actually. And with the proper physical examination and evaluation, we assess that the patient is actually toxic. He doesn't look good. He's very tachycardic. He's poorly perfused, and his fontanelle is full. So do I have like a CNS infection? So an infection in the brain. And like when I look at the thoracic incision here, like I say, well, it's a little bit red, but I've never seen this patient before. So then I rely on the heart doctor, and the surgeon is actually saying, do you know what? It looks exactly the same as it was for a while. So I don't think it is infected. The mediastinum is stable, which means that I don't think there's an infection deep here where the surgery happened. But again, those bring a lot of doubts about that. So of course, we're going to ask a lot of microbiology labs. And here, I'm just going where the money is, and I'm talking about a few, but there would be more that we would test in that scenario. So we would look for the virus, right? The mom had a virus, the baby has been in the hospital. So we would take a nasopharyngeal swab. You all have them during COVID, so you know what that is. And then of course, we would do blood culture to try to find the potential bacteria that we think might be in the blood of this baby. We would also test for HSV in the blood, because as we talked earlier, there's viruses that can give sepsis, and HSV is one of them, mainly in little babies when they've been exposed. And also we would do a CSF culture and PCR. And I'm going to ask here, how long, does it take for your results at your center to come? Or how long do you think, if you're not working in medicine directly, how long do you think it would take for us to have not necessarily the final results, but based on those tests, having some sort of sense of what that may be based on our results? So do we get some votes here?
We have 11 votes. 24 to 48 hours is winning, 55%. Got 25% for 6 to 24 hours, and no one has said 6 hours. So no one has said they'll get their results within 6 hours.
So this is pretty accurate. We're going to get a lot of those results 24, 48 hours, but some for the AMR test, I have to unfortunately tell you that it usually takes much more than 48 hours. So in that context, as a physician, I had to start broad spectrum antibiotics and even antivirals. So here with these combination, I would have 2 drugs that are toxic for the kidneys. Then I would start IV fluids. There's pressors that were started by the ICU doctors. And in that context, because I'm not sure exactly what I'm dealing with, I'm adding a second antibiotic that is the tobramycin, because it has a double gram-negative coverage. But then the ICU doctor tells me, do you know what? This child is just more and more unstable. And I'm well, I'm probably facing AMR, right? So I'm changing to cefotaxime with meropenem, saying, yeah, it's the big gun. This is going to work. This patient is going to get better. And then, of course, I'm doing more imaging to see if there is a deep infection in the chest that would require to go to the OR for cleaning. And here, do you think there would be a role of point of care in this situation, either by voting or like show of hands?
93% say yes.
Yeah, of course, because it's like a diagnostic. We don't know. There's many things, many factors that are clues, but it's hard to piece all of them together. So just to finish that case here, we got the nasopharyngeal swab. There were no viruses, but that took 24 hours, which is not bad, but again, that was long in that context. The blood HSV PCR was negative, took 2 days, and then hopefully we had a little bit of information from the CSF, so the liquid surrounding the brain, and that showed like no sign of inflammation, so 15 of leukocyte would be normal in that age group, so that was good, and the culture became negative. But where the money was the blood, right? And here we found an E. coli, which is a gram-negative bacteria that has a lot of factors that can promote sepsis, unfortunately, and indeed it was resistant to meropenem, but guess what? I was on meropenem and resistant to ciprofloxacin, so couldn't use that either. Thankfully, it was susceptible to tobramycin, so that double gram-negative coverage did help that patient. So with that information now, I'm able to tailor my antibiotics. Although they will be broad, they will be tailored to the need of my patient. So I stopped the vancomycin, stopped the acyclovir, good, because those are nephrotoxic, so I want to get them out of the way as soon as possible. And then in the meantime of getting those drugs, those fancy drugs that help with carbapenem-resistant antimicrobials, I'm like, well, I'm going to start an infusion of meropenem, so at least it's resistant, but I'm going to improve my pharmacokinetic, and hopefully that might help my patient. And of course, it's an SOS to the pharmacist, like what extra drug can you get your hand on that could help my patient? And in that case, like in other cases, sometimes we can get our drug with those more new drugs, and ceftazidime avibactam is one of them. But then I have to have this discussion with the family, right? I'm very sorry, your baby has like a multi-drug resistant organism, and that's why he's so sick. And now I will recommend to start a drug for which, unfortunately, hasn't been tested too much in a neonate. However, we know that the ceftazidime is very safe, so part of that medicine is safe in the child and well used and very often, but the combination avibactam is less been used. But we're still gonna start that because we have to find a drug that works for your baby. So those are very hard discussion, and usually the parent will say, well, when are you going to know more about this? And for the PCR to know if it's carbapenemase or another type of resistance, it takes a while. So often I'll get that result about carbapenemase presence on day 6. So it's been a while, then every day I'm asked by the patient. So what is happening in the lab actually? So here I took pictures in the lab in Quebec last week, and you can see that we have all sorts of ways to getting at antimicrobial resistance, right? So we do the culture first in the blood culture, and then we take the blood culture, we put that on a plate, and then we can isolate the colonies. If there is more than one morphology, then we'll all separate them. And then we have to culture them again to do the resistance testing. So the resistance testing might be with discs, as you see on the top, and also it can be with the e-test, so it can give us a sense of what's the concentration of antibiotics that will kill this bacteria. And otherwise, we have cards and other techniques that you see on the right that can help with knowing what's the threshold of antibiotics that works or doesn't work for such a bacteria, and help us identify the susceptibility or the resistance to antibiotics. But beyond that, once they are resistant to, for example, meropenem, those carbapenem, then we have to do further testing to know if it's an enzyme, a carbapenemase that is present, or another mechanism that is at play with our patients. So how long would it take for sensitivity results to arrive at your center, or what you've heard from some experience?
53% are saying 24 to 48 hours. A third are saying greater than 48 hours. So quite some time.
Yeah, quite some time. And a lot can happen to these patients during these very important hours.
If we could go back a second to the pictures with the plates. So how long does it take to grow a colony like that of the Pseudomonas or the Streptococcus that you can then put on the plate to do the sensitivity testing?
So from the blood that we take from a patient, then we have to do a blood culture, right? So we put it like in the media that will grow the bacteria and enhance their growth, and that can take like around 24 hours. So 18 to 24 hours would be like a typical time. And then we take those and we put it on the plate, and then the plate takes an extra 18 hours. Then we isolate the colonies, and once we have the colonies that are isolated, then we're able to do the kind of plates I'm showing there, or the card I'm showing on the right side. So that's an extra about 24 hours. So we can cut down a few hours here and there, but the thing is that we have the technologies that come during the daytime to do that work. So it ends up that a lot of steps, even if they're a little bit shorter than 24 hours, they actually take like 24 hours like to move along in the hospital with the flow that we have.
Can we make bacteria grow quicker?
No, we cannot, unfortunately.
In the lab only. Okay, so what about the viral tests? So like the nasopharyngeal swabs or the lumbar puncture test for viruses?
So it depends on how you have access to, right, in your hospital. So for the PCR, so if it's something that you have a lot of tests that are done, let's say COVID, then a high throughput machine, you can have them like done every 24 hours or every 12 hours or even every 6 hours, right? So you have your staff that will start runs with a lot of samples from a lot of patients at the same time, and then finish this one and then can start another one. So it depends of like the number of tests that you get asked for during like a certain period of time. And some tests, unfortunately, like the HSV, we don't necessarily have the capacity to detect it from the blood every day. We might have only enough personnel to do it every other day. So in the meantime, you have to give a cyclovir not knowing, right?
And so it's interesting, I'm taking Lean Six Sigma training, and one of the things I was told you never do is you never batch, and all I could think about was the sort of the special tests in the lab. So is it the human resources? Is it the cost? Like what is the reason to batch?
It's mainly a question of human resources, and also like there are things that are kits that we buy, and some of the kits, like if you buy like a plate, and that's for PCR, like that plate, you will want to run as many samples as you can on that plate, so it decreases the cost per run and per person. Yeah.
Okay.
It's very complex, and that operation is all calculated before we implement a test.
Okay. It's complicated. Okay, let's go to the next slide. So we wanted to get a sense of so I think we've demonstrated here that it would be great if we had rapid access point of care testing. So what are we doing already that's point of care testing? So Dr. Gu, could you explain or talk about your experiences with rapid tests in the emergency department?
Yeah, absolutely. So we're actually quite limited in our access to rapid tests, at least in the UH and Emerge. We have two main ones that we do by the patient bedside. So that's the point of care glucose as well as the urine dip, and these are both done by the nurses. So it also depends on nursing availability, whereas like the urine dip can take less than 5 minutes to result. It depends on your human resource capability at that time, and oftentimes it can take up to a couple hours to get the result from that, just because the nurses are busy with other tasks. In terms of other things, the COVID rapid tests we had earlier during the pandemic, we actually don't have that available to us anymore. And there's two additional tests, the rapid HIV as well as the venous blood gas, that are point of care tests, but they get sent to the lab to be resulted. So technically you could test them within like 15-30 minutes, but because they get sent to the lab, often we don't get a result for at least 30 to 60 minutes.
In the intensive care setting, the arterial blood gas machine is in many centers. It's actually in the ICU, and the respiratory therapists and the nurses can run it, and they'll get the little printout on the cash register paper that you'll read. But then, as you said, it will go to the lab, and the final sort of formal read will come up on the EHR system. Okay, where do you think Dr. Isabel, where do you think the future is for point-of-care testing?
That's a good question. Well, closer to the patient would be ideal, obviously, but there's a lot of considerations in these decision-making. Some is health economics, some is also like the HR capacity, right, that we have. Like we hear it on the news all the time, right? We have limited staffing in the emergency rooms, like everywhere. We have limited staffing everywhere. So concentrating it to the lab has that advantage, right? Less staffing for more places in the hospital that can be tested, but then the disadvantage is the turnaround time for the patient. So we have to think it through for each situation.
So implementation, challenging. Wonder if we could go to Gino now. We'll flick the slides forward. So Gino is Angelis, works at CDA, formerly known as CADIF, Canada's drug agency. And so Gino, can you walk us through, there's a lot of people here in the audience who are in the medical life sciences, labs, technology, a couple farm people, how we get these really cool innovations that might solve the problems that you've heard us talking about, how do we get them to market?
Thanks very much. So happy to be here. I guess I'll start just to answer quickly. It's complicated. First, maybe I'll talk a little bit about who we are and a little bit about HTA before I get there. Just to be clear on what we do. So Canada's Drug Agency, we're not-for-profit responsible for providing healthcare decision makers with really objective evidence to help make these informed decisions on optimal use of these health technologies. So this obviously includes drugs, as our name pertains to, but we also look at non-drug work. So we do look at diagnostic tests, medical, dental, surgical devices and procedures. And then in addition to that, we also provide advice and recommendations and tools as well. So just to be very clear, we don't make any decisions about funding, nor do we conduct clinical trials. Rather, we gather and review and appraise evidence, and then we bring it together to provide to various committees that we have at the CDA. So starting with that, and then in terms of like what do we mean by HTA, health technology assessment, it really is this multidisciplinary process. It uses explicit methods to determine the value of a health technology at different parts of the life cycle. So again, the purpose is to inform decision-making in order to promote this equitable, efficient, high-quality health system. So, with that, what's this role that we play? So, starting with Health Canada as the regulator, where they're looking to see if a technology is safe and does it work. Where we fit in as the Health Technology Assessment Organization, we're interested, how does it compare with existing treatment options? Is it good value? So very different from the regulator. And then from there, really, we conduct these assessments that all look very different. And it really is dependent on the technology and ultimately the evidence needs. And so our work is geared and tailored for deputy, assistant ministers of health, health authorities, cancer agencies, and other health service delivery organizations. And so, they're asking the questions, is it affordable? Is it feasible? Is it needed? And that's where we play this role in looking at the evidence to try to close and bridge that gap. And so just moving back to our assessments, we look at the clinical safety and effectiveness of these technologies. And so we would look at, different types of research, including randomized control trials, and then depending on the technology, looking at health data and health system data. And then part of our assessments, of course, we're looking at economic analyses and considerations, so looking at costing. But those are the two that most people are familiar with. We go beyond that, so we are looking at things like social and ethical considerations, kind of assessing the impacts of the health system, looking at implementation considerations, if you will. And then very important with all of our assessments is ensuring we are getting that patient, clinician, and industry engagement, those important perspectives to kind of help round out all of the different information that goes into our evidence assessments. And so a common question that we often get is how do we identify these topics? And so very different. I'll get into a bit more details about how how the drug process differs from the device process. But in terms of the different types of medical devices and test technologies that come to us, these are requests that we receive from HCA, or decision makers rather, from participating Canadian publicly funded health care jurisdictions. So this could include federal, provincial, territorial health ministries, the health authorities, cancer agencies, and then national and regional healthcare programs. And so part of this is the reactive work, the requests that come in. The other part of it is we have a team of researchers who look at more proactive work. So looking ahead, we do what we call horizon scans. So you might have heard of some different types of reports we put together. We refer to them as watch lists. And so these are just looking ahead at different types of technologies that have the potential to kind of shift the way healthcare is provided over the next few years. So a bit of a mix in terms of how we identify the topics. And then there's the how we do it. And I think I've alluded to that. You know, we do look at clinical, economics, implementation, but essentially the questions we're trying to answer, you know, is it safe? Who does it work for and when? Is it better than what we already have? From an economic lens, does it provide value for money? Can we afford it? These are all different types of questions that our HTAs do try to address. I mentioned the evidence that we look at could come from clinical trials, from systematic reviews that synthesize evidence of clinical trials. From an economic lens, the cost of the technology, the cost of the healthcare resources, the productivity loss. How does that compare to some of the benefits? Does it make me feel better? Does the health technology use make it more convenient? And then looking at the patient perspectives and experiences as well. Very broad questioning, but like what's important to patients? Why does it matter? Why do patients expect, what do they expect from these health technologies? How do they interact with these health technologies in their lives? What helps, what hinders? So these are the types of questions that we try to address, and we'll look at published literature, but we'll also conduct engagement sessions ourselves with these different groups to really hear firsthand on how these technologies impact their day-to-day lives.
Could we?
So I'll probably.
Sorry,
Sorry?
I was going to say, could you maybe just speak a little bit now to how the HTA, or the health technology assessment, is used? How would then a decision maker use it? I think you speak to that a little bit on this slide.
Yeah, so I guess if you can go back to the slide just before, like what I would start with is just looking at the landscape from the drug perspective. And so here what you're seeing is something a bit more streamlined, if you will. So starting with the regulator, Health Canada, again, is it safe and does it work? Moving on from there is where we HTA really fits in. Is it good value? And then from there, we have some various committees that will provide non-binding recommendations where we move on to the price negotiator. So in this case, when we're talking about drugs, it's the Pan-Canadian Pharmaceutical Alliance, or the PCPA, where that price negotiation takes place. And then ultimately from there, it's the decision maker, the funders, and that's the FPT drug plans of these health and cancer agencies. So a streamlined process, I would say a more streamlined process for drugs. And now if you can go to the next slide, this is where things get a little bit messy. And this is the point that I want to make here, where it's very different, I will say, not as streamlined. Of course, we're still starting with Health Canada as the regulator, so their medical devices bureau would be the ones, providing this regulation. But then from there, we're talking about, access, quality, timely, affordable care. So HTA, you'll see in the red boxes there, happens at different levels. So ultimately, the decisions to reimburse medical devices in Canada it's highly decentralized. So most provinces, their budgets are allocated to hospitals through, a geographic or operational health region or authority. Purchasing and procurement decisions largely take place at the level of the regional health authorities or at the individual hospitals. So very different from what we're seeing on the drug side. And then the way that HTA plays a role, it's It's not consistently applied across new medical devices as well there too. So very different where you have a drug, you'll have a sponsor or manufacturer that will submit for their reimbursement process, for a reimbursement review. That's not the case with medical devices at all. So there is no reimbursement process that takes place for medical devices. And then I would say that the presence of these HTA bodies within hospitals and health regions, they also vary widely across Canada. So ultimately, decisions to fund these new technologies, they're made at the hospital administrators, and sometimes without even formal HTA process to support decision making. So very, very different from the drug side versus the devices. And it's what causes a lot of, it makes things a bit more complicated, if you will.
I sit on the Ontario Health Technology Advisory Committee here in Ontario, and I can tell you that we would probably sit, I guess we're the red box between the Ministry of Health, and we make a funding recommendation for technology. And one of the things that we've found is that it's hard to implement that recommendation without a program in the Ministry of Health to help shepherd it through. So for instance, devices that, endovascular devices, for instance, Core Health can help. There'll be a program manager or someone within Core Health who'll pick that up and help it get to the front lines. The same for Cancer Care Ontario, so any sort of like cancer-related treatment things. But then things like intermittent catheters or gait aids, or some of the things that we've reviewed and made positive recommendations on, without a programmatic home within the ministry, it's really hard to get them. And we have some senior hospital executives that sit on the committee, and they've sat in these decisions where we've had, there's maybe really good evidence that it's cost effective, so it has good value, the patients prefer it, it just sort of seems like a no-brainer, and they say, yeah, but this is going to have to come out of the hospital's global budget. So there's an opportunity cost. The whole point of HTA is you're supposed to identify the highest value thing, but what am I going to cut? Where's this funding going to come from? And so in the absence of sort of hospitals at the local hospital level deciding to pick it up, then we're looking at the ministry to say, okay, well, can you create a new funding mechanism for this? And that can be very challenging. And like in some very expensive technologies, like very advanced imaging devices, or like PET scans and high fidelity CTs and MRIs and things like that are incredibly expensive, they're often directly funded from the ministry. So they'll get sort of like earmarked funding for those investments. So it's tricky, right? Mm-hmm. And I think, okay, do you want to talk about this, or we're sort of talking about that now?
Yeah, I think I've kind of summarized this already there, just, how the assessment takes place, the appraisal, and then ultimately how all this leads to decision making. So I think that's been covered. Okay.
So we wanted to then talk a little bit about some of these implementation issues. So let's assume this technology, it's been proven clinically effective. It's accurate. It's going to help clinicians make decisions. So let's say we're at your hospital and you are totally in and you want to get this to your center as a PEDS ID doctor. Are you going to be able to do that? Like how would you go about doing that?
Yeah, it would take a lot of homework. So first of all, I have to review the literature, right? So like in my own assessment of like what is available, like what point of care tests are available for the medical question X. So like if we talk about sepsis, okay, what is there on the market that has been approved to help me with the diagnosis of sepsis? And then based on that, I'll say, okay, if there's 3 different tests, for example, I need to compare them, right? What is their performance characteristic? Is there one that is more sensitive, another one that is more specific? How do they compare? And then after that, I get more into, okay, so what equipment on top of that would I need? And after that, I would ask myself also, okay, so what is the estimated impact of adding this test for my patient population here? So it is a lot of homework to do that. So, but that would be the starting point. And then let's say I identify a better test to respond to my need. Then I have to document all of that and get the approval and the funding. And the funding is complex. And I moved from Ontario to Quebec more recently. And again, when I changed changed of problem. It's like, oh, the process to get equipment in the lab is so different from one province to the other. So I had to learn like a whole new system. But again, like then we'll build a case, we'll explain like why we need it, we'll request the funding, but it does take time. And beyond time, it takes a lot of energy from like the people in the labs to do that. So having the help of like clinicians in ED or like pediatric intensive care unit or other like intensive care units supporting and explaining again why we need this is very helpful. And then we would go into like the more like operational considerations of that, like how could that be implemented? Where would it be? Like, do we have the space? Do we have the staff? Like, how would we train the staff? Who is going to be the point of care test? Is it going to be the nurses at the bedside that are already doing a lot of things, or is it better to have it centralized in the lab just for an operation facility? How am I like going to connect this like testing platform to my informatics system also? So the data is interoperable, so I can analyze it and use that data. So there's a lot of technical thinking that come into that, and that needs to be done like in an interdisciplinary fashion with a lot of people being involved. And that is just the start. Then we have to make sure that it follows the regulation, and also like make sure and set up like in what we call like a quality management system, like make sure that we have everything in place to say that the test is working as it should for the patient, that it is safe for the patient, and if something happened and the result is not accurate, we have a mechanism in place to resolve the issue and make sure that we solve the problem for the next patients. So there is a lot of thinking going through like the planning of an implementation test. And as laboratory medicine physicians, we are trained to do that. So we can help like other professionals that want to have access to other tests, but it is not easy.
So speak to your hospital's laboratory physician is what we've learned. Ada, what do you think? Do you think we learned anything from the pandemic and the use of the COVID-19 rapid antigen tests?
Yeah, I think we learned a lot from the COVID pandemic, actually. And I think the first thing is there was such a democratization of access to the rapid test, to the self-test at home, which I think was really great. So it was very equitable access. It was really spread to different populations, such as peri-urban, urban, to people in rural settings, and people with lower health literacy settings. So I think that's one thing that is really important, having a test that is really accessible, that is easy to use, that is easy to understand, and that is widely available for low cost or no cost, which we saw during the pandemic. And I think the benefits of having a rapid test we can see from a personal standpoint. So certainly from social interactions, gatherings, we all remember the time we had to do the rapid test before you could go in, and this certainly reduced the risk of transmission and reduce outbreaks that way. We can say the same thing in the emergency department. So when a patient gets a rapid test, is COVID positive, we can then allocate them to the appropriate zone or to the appropriate isolation or ICU or wherever they're going to be dispositioned to. So I think it was a really important test that gave us metrics that we could really act on, that was also low cost, at least to the emergency department, because we got them provided by the government. And I think additionally moving forward, it's really opened the conversation around self-testing and around testing in the future, so doing these rapid tests. I think people will be much more comfortable with using them, knowing that they are reliable, high specificity, pretty high sensitivity as well. And I think in the future, we'll definitely see more use of this point of care testing and self-testing at home and in the hospital.
Yeah, I was at a talk on Sunday, part of the International Sepsis Forum, and Derek Angus, who's one of the editors of JAMA, was there. And he actually asked the scientific community to declare success on how we know how to treat sepsis within the first 6 hours, and said sepsis is now an implementation problem, and that our efforts need to be on making sure that everyone is getting the right treatment within the first 6 hours. And he also really urged everyone in the room to think outside the box and said, you know, like 15 years ago, we would have never in a million years thought that people would be screening themselves for colorectal cancer at home. And we are actually at a stage now where that is a reality and that is a possibility. And we're able to actually identify those people who are at higher risk of it and do need to have the colonoscopy as opposed to having to screen everyone with a colonoscopy. So, you know, there are examples of this working and there are examples of this having been implemented already. Gino, I'm wondering if you can, in terms of the evidence and the evidence base, like in COVID, we sort of learned on the fly. And we were evaluating evidence in real time. I'm wondering what your thoughts are on how much evidence do you think we need on a novel diagnostic test or point of care test in order for, I know CDA is not going to make a funding recommendation, but like what kind of evidence do we need to see in order to be confident that this is a test that we should be considering as high value for our health system?
That's a great question. I think, you know, it obviously really depends on context here too, and budgets and all that fun stuff. But, you know, it's so different from the type of evidence you see with drugs. You have these high quality randomized controlled trials taking place, you know, well done conducted studies. It's always been very challenging when we do our reviews with the different devices and tests, because that's not always the case. We don't always have these high quality randomized controlled trials. And so we have to work with what's available, but ultimately just noting what these limitations are and being very transparent and clear, you know, that it's not maybe the highest quality types of studies. But ultimately it really just depends on that threshold and that we're comfortable making these decisions. As an HTA organization, we always review all evidence with the same scope, you know, and so we're always clear on what the limitations are, where improvements need to be made, what more research needs to be conducted. And so it's a good question. It ultimately depends on the types of decisions that need to be made at that hospital level. But I would say that a lot of the work that we've done, we are seeing a lot of more improvements. We are seeing a lot more types of studies come out with the different technologies. Things are getting better. So a lot of great things are happening.
So I think my understanding is that CDA also provides advice, correct? In terms of how, like what you would need for a submission. I'm not saying that everyone should now submit to CDA and overwhelm their technology committee, but does your organization provide advice in terms of what sort of package you would need to put together to sort of be more likely to have a successful review either at CDA or at a regional health authority at your local hospital?
For our drug program, we have that program in place. For its non-drug, we don't. And so we do have an expert committee, our health technology expert review panel. I would say the types of recommendations that are made with this committee, they're not necessarily funding recommendations, but rather more optimal use. How do we use this technology appropriately? Again, very similar to the other committees we have at the organization, but again, non-binding. And so the committee does provide more of a guidance, I would say, for decision makers on, you know, what type of context to look at, when tests would be appropriate, and of course the quality of evidence. So it's very different from our drug work when we're talking about more of the non-drug work, if you will.
Okay, so we're going to wrap up. I'm going to ask everyone to tell me where you think the future is. So I'll start with you, Gino, because you're still unmuted. Where's the future of point-of-care testing in Canada from your perspective?
I think we're heading in the right direction here. You know, excited to see where, you know, from that evidence lens, where we go from here. I think we're starting to understand, we're getting better at conducting research, getting better at understanding what type of evidence we need. So I think the future is bright and looking forward to seeing more of these types of technologies come to light so we can appraise them and help decision making.
Okay.
Yeah, I'll follow through with having those technology implemented safely for the patient in multiple places. So they're closer to the patient, but they're safely used.
And I would say from an eMERGE perspective, I definitely see more collaboration between lab medicine, eMERGE, ICU, the different players in the healthcare space. I think there needs to be much more conversation that way so we can actually implement these technologies and get good evidence about their benefit.
All right, and I will end by saying, I wonder if the antimicrobial strategy for Canada and future work on a national action plan for sepsis, maybe these are how these programs and these action plans, maybe this is how we get these tests to the front lines, make them the standard of care. It's a thought. Okay, that's it. If there's questions, I don't know if we have time for questions. I'm trying to see. Does anyone have any questions for us quickly? Yes.
When I saw the slide with the pharma process, it reminded me, and without telling my age, I was there when we introduced CDR and the Mise and all the process. And I was a representative of a pharma company, and we were at the table co-creating the processes. I have many questions that I could ask today, but I will resume it in one question. Do you see a role for industry to be partners with the HTA in developing the point of care or diagnostic in general pathways to get, we heard it this morning, it's difficult to introduce innovation in Canada, and unfortunately, there's a dialogue that it's difficult to take place. I wish we could co-create, like we did with CDR and ENICE and PCPA when I was in the pharma world.
So as a HTA PhD student, I will say, I think the answer to this problem is in the concept of life cycle health technology assessment, where we need to have technology with potential, innovative technologies that have the potential to be amazing, embedded into the health system with real-world evidence collected, so that we can make ongoing decisions about whether or not it's working, it's providing value. Recognizing, though, that there's the potential that we're going to say this technology should not continue, but that there's the potential that it will continue to grow and spread and scale out through the health system. I think that's where we're going. I think it's too expensive and timely to do randomized control trials on absolutely every single technology or drug. And the fact that we have access to data now, like real world data from electronic health records, this is how we're going to be generating evidence in the future. And so I think that's how we need to be focusing our efforts there. Gino, do you have any thoughts?
No, I think that's really well said. And I would just say there's always room at the table for industry. I think we all need to come together as a collective to sort this out here. And so I look forward to the future. But these are all common issues that we've been facing with. There's always, it's the changing technology landscape. There's just so many issues there. But I think it's going to take all of us to come together to sort this out. And so hopefully we can do this in the future.
Thank you. Thanks for the discussion. One of the things that you was not really mentioned here, and I'm really curious about your thought, is the consumer-based health monitoring. Nowadays, everybody seems to have some sort of device that they're using. How do you integrate that into medical decision-making at the front lines and actually making use of such a vast amount of data to make that clinical decision?
Do you want to talk about Heather Ross's program? Do you know about it? Okay. So I truly think this is an area of immense opportunity. And actually, Dr. Heather Ross, who's a cardiologist here in Toronto, has been working with Apple and the Apple Watch on this technology for patients with heart failure and other cardiac conditions. So yeah, this is a new frontier in health technology for sure. The whole issue of wearables and sort of real-time monitoring of someone's health status, absolutely.
And using it into the clinical decision making, even
yeah.
prior to getting to the hospital.
The Apple Watch is alerting a nurse practitioner that they need to call the patient and tell them that there's something that they need to do. Yeah,
and I will say from the emerge perspective too, a lot of patients will come in saying, I have palpitations, my heart rate is like 150 on my Apple Watch. I think the Apple Watch 5 can print out your ECG, and it can do like a basic reading, say you have like arrhythmia. And these patients will often come in with these concerns, and then we can do an ECG, do the full workup in the emergency department to corroborate or kind of refute what they found. So I think it can be helpful for alerting like possible, concerns about tachycardia, arrhythmia at home. I think there's a lot of room for development in the future as well.
All right.